Welcome to the Deep Dive, the show where we cut through the noise and get straight to the critical insights you need to be truly well informed.
Hmm.
As specialist clinicians, you know the scenario. You've successfully completed a complex arterial procedure. But that's just the beginning, isn't it?
Absolutely. That's often where the real challenge begins, the critical phase of post-procedure follow-up.
Exactly. How do you define that optimal surveillance strategy amidst rapidly evolving interventions and, let's be honest, often just a sea of information?
Well, that persistent challenge is precisely why the Society for Vascular Surgery guidelines are so vital.
Right.
Today, our mission is to embark on a comprehensive deep dive into the Society for Vascular Surgery practice guidelines on follow-up after vascular surgery arterial procedures.
Okay.
We're going to try and distill the most critical insights from these extensive documents, giving you, our specialist clinician listener, a structured and hopefully actionable understanding of recommended approaches across the entire arterial tree.
So we'll be clarifying essential testing methods, the key indications for reintervention, and those all-important optimal follow-up intervals.
That's the plan. And importantly, where high-quality evidence might be a bit scarce, we'll look at the expert consensus that helps bridge those gaps, offering guidance you can really rely on in practice.
Good point. And we should probably touch on the methodology behind these guidelines, too.
Yes, definitely. It's important to remember the rigorous process. They were developed by an expert panel using the Grading of Recommendations Assessment, Development, and Evaluation System, or GRADE.
Grade, right.
So this means recommendations are graded as either strong, that's designated as 1, or weak, designated as 2.
Okay, 1 strong, 2 weak.
And the quality of supporting evidence is also graded. High, moderate B, or low C.
And that distinction between we recommend and we suggest, how does grade influence that?
Good question. We recommend signals a strong recommendation, grade 1. This generally indicates that the benefits of the intervention or surveillance strategy clearly outweigh the risks. But interestingly, you might find strong recommendations even with low-quality evidence.
Really? How does that work?
Well, it often happens when the costs and risks of surveillance are minimal, but catching a potential complication early is deemed critically important for the patient.
Ah, I see. The potential downside of missing something outweighs the low evidence base for active surveillance.
Precisely. Conversely, we suggest denotes a weak recommendation, grade 2. This means the benefits and risks are more finely balanced, or maybe the quality of evidence is low, making the definitive path a bit less clear-cut.
Got it. So this deep dive is really designed to equip you, the listener, with precise, evidence-informed strategies.
That's the aim, giving you actionable knowledge to enhance long-term patient outcomes, detect complications early, and hopefully optimize resource utilization in your practice.
Okay, so to navigate this extensive landscape, where are we starting?
We'll begin our journey with the extracranial carotid artery, then move through the thoracic and abdominal aorta, then the mesenteric and renal arteries, and finally, a detailed exploration of lower extremity arterial revascularization, covering both open surgical and endovascular interventions.
Sounds like a comprehensive roadmap. Let's get started.
Right.
So before we dive into specific arteries, let's just lay the groundwork. The fundamental principles of follow-up and surveillance. What's the key distinction we need to keep in mind?
It's a crucial difference, actually. Clinical monitoring is, well, the simplest approach. Just your periodic vascular history and physical examination.
Standard checkup, basically.
Right. Then there's surveillance, which is more proactive. This involves the routine, planned use of serial objective testing, typically duplex ultrasound, even in patients who are completely asymptomatic.
So the idea is to catch things brewing under the surface.
Exactly. Catching issues that might not be clinically obvious yet.
And then if symptoms do appear, or if surveillance picks something up, that's when we move to diagnostic testing.
Precisely. Diagnostic testing comes into play when signs or symptoms suggest a problem, or maybe an abnormal finding pops up during routine surveillance.
And that includes things like?
Think limb blood pressure measurements, more detailed duplex ultrasound, maybe CT or MR imaging with or without contrast enhancement, and then, of course, catheter-directed angiography for definitive evaluation or intervention planning.
Okay. So why all this effort? What's the ultimate goal of this intensive follow-up?
Well, the primary goal is really the early detection of significant problems. We want to identify issues when they can be managed most safely and effectively, ideally, before they manifest clinically.
Makes sense.
But it's a delicate balance, isn't it? You're trying to minimize patient disruption, costs, potential risks from testing itself, while still ensuring that necessary vigilance.
Right. And it's important to note, these guidelines focus mainly on the testing and imaging aspect.
That's a key point. They emphasize vascular laboratory testing and imaging, not specifically delving deep into medical management or risk factor modification, though those are obviously crucial too. And one more critical thing. All vascular laboratory testing must be performed by qualified personnel in an accredited facility. That's non-negotiable for reliable results.
Absolutely essential. Okay, let's turn our attention now to the extracranial carotid artery. We know carotid endarterectomy, CEA, has been the standard for high-grade stenosis for a long time. But carotid artery stenting, CAS, is increasingly used, especially for those patients deemed high risk for open surgery.
That's right. Both procedures aim to prevent stroke, but their modes of failure can differ somewhat.
How so?
We primarily see two main mechanisms. First, there's neointimal hyperplasia. That's an early sort of overgrowth of smooth muscle cells within the vessel wall, typically happening within the first 2 years.
Okay, the early failure mode.
Right. And then later on, you can see progressive atherosclerosis, just the ongoing development of plaque in or around the treated area.
And for CAS specifically, you mentioned mapping patterns.
Yes, with CES, Duplex ultrasound helps us map distinct morphologic patterns of what we call instant restenosis, or ISR.
Can you describe those?
Sure. For instance, type 1 is focal, maybe less than 10 millimeters long, right at the end of the stent. Type 2 is similar, focal, less than 10 millimeters, but within the stent body.
Okay.
Type 3 is more diffuse, longer than 10 millimeters, but still contained within the stent. Type 4 is also diffuse, greater than 10 millimeters, but it's characterized by proliferative lesions that actually extend outside the stent boundaries. And type 5 is total occlusion.
Wow. Okay, so identifying these different patterns can actually guide how often we surveil.
Potentially, yes. A type 4 pattern, for example, might warrant closer follow-up than a simple type 1.
Interesting. What about the actual incidence of restenosis after these procedures? And how clinically significant is it?
Well, the rates do vary. After CA, the ACS trial found about a 7.6% rate of greater than 60% restenosis. After CA, some studies show around an 18% incidence of over 40% ISR, with a projected 5-year rate of about 6.4% for the more severe, over 80% ISR.
And what did the big trials like CREST show?
CREST famously showed quite similar restenosis or occlusion rates between CES and CEA at both 2 and 4 years, around 6% or so.
So, not much difference there.
Not in CREST, no. Though EVA3S did show higher rates for CAs for a moderate 50% restenosis, but it was pretty equivalent for severe 70% stenosis.
And the clinical impact? Is asymptomatic restenosis a major worry?
That's really the ongoing debate. Symptomatic restenosis is actually quite low, maybe 0 to 8%, and the risk of stroke or occlusion from asymptomatic restenosis is also generally considered small.
So that leads to different management approaches.
Exactly. Some favor just careful clinical follow-up alone for asymptomatic lesions. Others, citing work from O'Hara, Mansour, and de Groot, argue for a more aggressive operative approach for those high-grade, say, over 80% asymptomatic lesions.
Why the push for intervention if they're asymptomatic?
The concern is the difficulty in predicting which of those high-grade asymptomatic lesions might progress rapidly to occlusion, potentially causing a stroke without warning.
I see. What are the known risk factors then? Who's more likely to develop restenosis?
Diabetes is a big one. It's a known predictor for early and often aggressive intimal hyperplasia and ISR, particularly after CAS.
Okay, diabetes is key. What else?
Other factors include younger age, female sex, hyperlipidemia, and certainly smoking, especially after CEA. And remember that type 4 ISR morphology we talked about. That pattern, along with diabetes, seems to be an independent predictor for developing high-grade ISR after stenting.
Got it. Now, duplex ultrasound is clearly our workhorse for follow-up here. You mentioned criteria need to change after CA.
Yes, absolutely critical point.
Yeah.
DUS is paramount, non-invasive, safe, readily available. But for CES, you cannot just apply the standard DUS velocity criteria used for native carotid disease.
Why not?
Because the stent makes the artery more rigid. It changes the biomechanical properties, reduces compliance. This alters the flow pressure relationship, so velocities naturally increase after stenting, even without a significant narrowing. They don't correlate linearly with stenosis in the same way as in a native vessel.
So the numbers mean something different.
Exactly. You need significantly modified higher velocity thresholds to define degrees of stenosis after CAS.
How is the exam itself performed?
You'll perform a bilateral exam using a high-resolution linear array transducer. You meticulously assess stent apposition to the vessel wall, check for full lumen expansion, and look closely for any signs of neo-intimal hyperplasia using B-mode imaging. You map those morphologic patterns we discussed.
And the measurements?
You measure velocity waveforms, peak systolic velocity, or PSV, and end diastolic velocity, EDV at multiple locations. In the proximal common carotid artery, throughout the stent segments, proximal mid-distal, and in the distal native internal carotid artery. You specifically record the maximum PSV within the stent, and then you calculate the ratio of this maximum internal carotid artery PSV to the common carotid artery PSV. That's the ICA-CCA ratio.
Okay, so what are these critical modified DUS criteria for ISR after CAS?
Right, this is key. The guidelines, referencing several studies, provide specific thresholds. For example, to call something a 50% or greater diameter reduction after CAS, you're typically looking for a PSV of 220 centimeters per second or greater, and an ICCA ratio of 2.7 or greater.
And for higher grades, like 80%.
For an 80% or greater diameter reduction, the suggested thresholds are a PSV of 340 centimeters per second or greater, and an ICA ratio of 4.15 or greater. CREST actually used a threshold of 300 centimeters per second for 70% stenosis.
So significantly higher numbers than native vessel criteria.
Much higher. And it's crucial to remember that B-mode imaging, actually looking at the plaque or hyperplasia, is essential to supplement these velocity criteria. You use both together.
Is there any move to adjust criteria after CEA as well?
There's emerging data suggesting maybe some revisions are needed after CEA2, especially with patch angioplasty, but the guidelines state that firm recommendations really await further studies. For now, the major validated adjustments are for CA.
Okay, let's summarize the specific SVS recommendations for extracranial carotid artery follow-up then.
Sure. Recommendation 1 is strong, based on moderate evidence. After either CEA or CES, we recommend a baseline duplex ultrasound fairly soon, within 3 months.
Okay, baseline first.
Then surveillance every 6 months for the first 2 years, and annually thereafter if things are stable. Stable means no significant restenosis or ISR found on 2 consecutive scans.
And after it's stable, stop surveillance.
No, actually. Given the small but real risk of delayed issues or progression elsewhere, lifelong surveillance, perhaps shifting to every 2 years, should probably be maintained.
Got it. What's the next recommendation?
Recommendation 2 is also strong, moderate evidence. This applies to high-risk CAS patients.
Define high risk again.
Those with diabetes, that type 4 ISR morphology, anyone who's had prior treatment for ISR, prior cervical radiation, or heavily calcified lesions pre-stenting. For these patients, we recommend DUS surveillance every 6 months until stability is clearly established, and then annually after that.
So more frequent initial surveillance for the high-risk group.
Exactly. And recommendation 3 is strong, but based on low evidence. It states that DUS after CAS must include those Doppler PSV and EDV measurements. We discussed native CCA, stent segments, distal native ICA using the modified velocity criteria. And again, emphasizing that B-mode imaging should always supplement those velocity numbers.
Okay, that's clear. So, to quickly micro-recap this carotid section, the core message is the absolute necessity of tailored duplex ultrasound surveillance, specifically adjusting velocity criteria for stented vessels and adapting the frequency based on the procedure type and individual patient risk factors.
Well put.
And maybe a quick memory jog for our listeners. Recall those distinct morphologic patterns of instant restenosis types 1 through 5 we discussed earlier, and think about how identifying one versus another might genuinely influence your surveillance strategy in practice.
Good point.
All right, let's test this with a clinical scenario. Imagine a 72-year-old female, history of diabetes. She underwent carotid artery stenting 6 months ago. Her baseline post-CA duplex was normal. Today, she's back for routine surveillance, completely asymptomatic. Her duplex shows a maximum PSV of 250 centimeters per second within the stent and an ICA-CCA ratio of 3.0. Based on the SVS guidelines, how should you interpret these findings, and what's the recommended next step?
Okay, good case. So those duplex findings, PSV 250 centimeters and ICAS-CA ratio 3.0, clearly fall within the criteria for a 50% diameter reduction or greater after CAS. Remember, the threshold was PSV E220 and ratio 2.7.
Right.
So this is a significant finding of moderate to severe insistent breast stenosis. Now, considering her history of diabetes, she's already in that higher risk category for aggressive ISR progression. Even though she's asymptomatic right now, SVS recommendation 2, the one for high-risk patients, strongly recommends continued duplex ultrasound surveillance every 6 months until a stable pattern emerges.
So not necessarily immediate intervention, but definitely closer follow-up.
Exactly. This finding triggers a shift to more frequent surveillance because of the identified ISR and her underlying risk profile. It highlights how surveillance findings, even without symptoms, directly impact the management plan. Excellent explanation. All right, let's shift our focus now, moving upwards to the thoracic and abdominal aorta. We'll start with thoracic endovascular aortic repair, or TAVR. When a patient leaves the OR after a successful TAVR, what's really driving our decision to, well, keep such a close eye on them with ongoing surveillance? What's the core rationale?
That's a really important question. Because with TAVR, we're not just fixing the immediate problem, like preventing an initial rupture. We're essentially signing up for a long-term commitment to monitoring.
A lifelong partnership almost.
In many ways, yes. The main drivers for surveillance really boiled down to preventing, or at least catching early, a few key potential issues. Things like endoleaks, persistent blood flow outside the graft, but within the aneurysm sac.
Right, the leak.
Or problems with the device itself. Can it collapse? Can it migrate from its original position?
Okay. Device integrity.
And critically, we're also monitoring for any further degeneration or aneurysm formation in the adjacent segments of the aorta, the parts that weren't covered by the stent graft.
So watching the native aorta too. Absolutely. Ultimately, it's all geared towards minimizing the long-term risk of aneurysm-related death. And this vigilance becomes even more pertinent for younger patients, maybe those treated for blunt traumatic injuries.
Why specifically younger patients?
Well, simply because they have a longer lifespan ahead of them, which means more time for potential late device-related complications to arise. And also, frankly, a higher cumulative radiation dose from potentially decades of yearly CT scans. That's a real consideration.
That cumulative dose is definitely a concern. Let's talk more about those failure modes. Endoleaks seem common.
They are. Incidence can be up to 30%. And they're not all created equal. Type 1 endoleaks leaks at the proximal or distal attachment sites, and type 3 endoleaks leaks through the graft fabric or between modular components demand pretty immediate attention.
Why urgency?
Because they indicate persistent pressurization of the aneurysm sac, carrying a significant risk of rupture. They are considered treatment failures.
Okay. What about type 2?
Type 2 endoleaks, which are retrograde flow from branch vessels like intercostals or the left subclavian artery, are more common and often observed initially. However, if they're associated with aneurysm sac enlargement, especially from the left subclavian, they often require secondary intervention rates as high as 56% at 2 years in some studies. And the presence of any late endoleak, one developing after the initial period, can be a predictor of decreased long-term survival.
So endoleaks are a major focus. What about device migration or collapse?
Also significant concerns. Proximal migration can mean the stent graft encroaches on the origins of the arch vessels, potentially compromising flow. Device collapse, sometimes related to oversizing or tight aortic arch curvatures, can lead directly to a type 1A endoleak and carries significant mortality risk.
And aortic remodeling.
That's particularly important in cases of chronic type B dissection treated with TAVR. Achieving thrombosis of the false lumen is a key goal. Without regular follow-up to monitor this remodeling process, reintervention rates can be quite high, up to 60%, often due to progression of disease in untreated aortic segments.
Given all these potential late issues, how long does surveillance need to continue?
Really, should be lifelong. Late complications are common enough, and we don't have a defined point after which they cease to occur.
And the preferred imaging modality? Still CT.
Generally, yes. CT scanning is considered ideal, despite the radiation risks. It gives excellent three-dimensional views and allows for delayed imaging phases which can pick up low-flow endoleaks that might be missed otherwise.
Okay. What about follow-up after traditional open surgical repair for a thoracic aortic aneurysm? Is it less intensive?
The data is certainly more limited compared to TAVR. Large multi-center trials involving the early TAVR devices actually showed very low reintervention rates after open repair in their control arms, around 2.1%.
Much lower than TAVR surveillance might suggest.
Right. So while specific long-term surveillance trials for open repair are scarce, the inherently degenerative nature of aortic aneurysm disease still suggests that some form of interval surveillance is prudent, even if the risk of graft-specific complications is lower.
Okay, let's shift downstream to the abdominal aorta and endovascular abdominal aortic aneurysm repair, or EVR. Its use has absolutely skyrocketed, hasn't it?
It really has. From maybe 5% of AAA repairs in the early 2000s to over 70%, approaching 80% now. Current guidelines generally recommend serial CT scanning to look for aneurysm sac expansion, endoleaks, graft migration, and structural failures.
What's the standard protocol, and are there alternatives emerging?
The traditional protocol has often been CT scans, sometimes with plain abdominal radiographs to check stent structure at 1, 6, and 12 months post-procedure, and then yearly thereafter.
That's a lot of CTs.
It is. And that's why, driven by concerns about cumulative radiation exposure and the risks of nephrotoxic contrast agents, there's been a significant increase in interest in using duplex ultrasound as a primary surveillance tool.
How does ultrasound stack up against CT for EVAR follow-up?
Standard color duplex ultrasound, or CDU, has reported sensitivities around 69% and specificities around 91% for detecting endoleaks, with better performance for those critical type 1 and type 3 leaks. Contrast-enhanced ultrasound, or CES, where microbubbles are injected intravenously, shows even higher sensitivity, specificity, negative predictive value, and overall accuracy compared to standard CDU. It's quite good at picking up low-flow endoleaks.
So how is ultrasound being integrated practically?
It's becoming a viable alternative to CT in many cases, particularly for patients with renal insufficiency, younger patients where radiation dose is a bigger concern, or patients whose aneurysm sacs are demonstrably shrinking over time.
Is there a specific point where you can switch?
A common approach now, supported by the guidelines, is that if the initial 30-day post-EVAR CT scan is entirely normal, no endoleak, stable or shrinking sac, and if the endograft can be adequately visualized with ultrasound.
Which isn't always possible.
Right, patient habitus matters. But if it is imageable, then the 6-month CT scan can often be eliminated in favor of CDU surveillance. Subsequent follow-up might then continue with ultrasound, perhaps annually, reserving CT for concerning findings, or if ultrasound visualization becomes difficult.
But if abnormalities are found early,
then a more rigorous CT protocol is generally maintained. It's also important to remember that even though the need for intense surveillance might decrease over time if things are stable, there's still a persistent risk of late endoleak development, maybe up to 15% in some series.
So vigilance remains key long-term. What are the limitations of ultrasound we need to remember?
The main ones are obesity, excessive bowel gas, which obscures the view, and sometimes a large ventral hernia can make access difficult.
How does the actual DUS examination technique differ for EVAR follow-up compared to, say, native vessel assessment?
Patients should ideally fast overnight to reduce gall gas. The exam uses both B-mode grayscale imaging and color flow Doppler. Key measurements include the maximum aneurysm sac diameter, measured outer wall to outer wall in both anteroposterior and transverse planes. Then, there's a meticulous evaluation for any pulsatile color flow outside the graft but within the sac. You look carefully at the proximal and distal attachment sites, any modular graft junctions, and throughout the entire aneurysm sac. You also specifically inspect potential endoleak sources like the inferior mesenteric artery origin and any visible lumbar arteries. Importantly, DUS dimensions for sac size correlate quite well with CT measurements.
Okay. And briefly, what about follow-up after open surgical repair for an abdominal aortic aneurysm? Less intensive again?
Generally, yes. Surveillance protocols for open AAA repair are less rigorously defined, mainly because the incidence of major graft-related complications is lower than with AVR.
What are the main things to look out for?
The most common complication is probably graft limb occlusion, especially if the graft extends down to the common femoral artery level. There's also a significantly increased risk, maybe threefold, of developing an incisional hernia after the large abdominal incision. Perinastomotic aneurysms forming right next to the suture lines can occur, though they're relatively uncommon, maybe 0.8% at 5 years, but increasing significantly by 10 or 15 years.
So a late phenomenon, potentially.
Yes. And similar to thoracic repairs, there's always the risk of future aneurysmal degeneration in other contiguous or non-contiguous segments of the aorta, reported in maybe 0.5 to 10% of patients long-term. So even after open repair, some level of ongoing surveillance is certainly necessary, though perhaps less frequent than for EVR.
Okay, that makes sense. Let's try to consolidate all that. Can you run through the specific SVS recommendations for the thoracic and abdominal aorta?
Absolutely. Let's break them down. Recommendation 1, strong, moderate evidence. is for TAVR performed for a thoracic aneurysm. Here, we recommend contrast-enhanced CT scanning at 1 month, 12 months, and then annually. A 6-month CT should be considered if there's any abnormality seen on that first 1-month scan.
Okay, 1, 12, then annually for aneurysm TVAR.
Recommendation 2, strong moderate evidence, is for TVAR performed for a thoracic dissection. The schedule is a bit more intensive initially. Contrast-enhanced CT at 1 month, 6 months, 12 months, and then annually.
So adding that 6-month scan for dissection.
Correct. Recommendation 3, strong moderate evidence, covers TVAR for blunt thoracic injury. The recommended schedule is contrast-enhanced CT at 1 month, 12 months, and then annually. Again, consider adding a 6-month CT if the 1-month scan shows any abnormality. Future studies might support longer intervals here eventually. Recommendation 4, strong low evidence, addresses open thoracic aortic repair. Here, the recommendation is for non-contrast CT scanning at 5-year intervals, much less frequent.
Right, 5-year intervals for open thoracic.
Now for EVAR. Recommendation 5, strong moderate evidence. We recommend contrast-enhanced CT scanning at 1 month and 12 months. Consideration should be given to more frequent imaging if an abnormality is detected at that 1-month mark.
1 and 12-month standard for EVAR CT.
Then, recommendation 6, strong moderate evidence, provides the ultrasound alternative for EVAR. We recommend Duplex ultrasound at 12-month intervals as alternative imaging surveillance if no endoleak or sac enlargement was detected during the first year, particularly on that initial CT.
Okay, the ultrasound switchover point.
Recommendation 7, strong moderate evidence, deals with EVAR patients who have contraindications to iodinated contrast. For them, we recommend Duplex ultrasound and non-contrast CT as alternative surveillance modalities.
Yeah, using both, potentially.
Yes. And finally, recommendation 8, strong, low evidence, looks at the whole aorta. We recommend total aortic imaging with non-contrast CT at 5-year intervals after either open surgical repair or EVAR, specifically to detect potential aneurysmal degeneration of other aortic segments over the long term.
That's a really helpful summary. So to quickly micro-recap this entire aortic surveillance section, we've really delved into the nuances distinguishing TVAR and EVAR protocols, highlighting that important shift towards using ultrasound as a primary tool when appropriate after EVAR, particularly after a stable first year. We've also outlined the less intensive but still necessary follow-up strategies for open repairs, acknowledging their lower immediate complication rates, but recognizing the persistent long-term risks like degeneration elsewhere. And for our listeners, maybe think back to those specific endoleak types we discussed. Type 1, 2, 3, and recall their differing levels of clinical urgency, especially as you interpret surveillance imaging after TVAR.
Good reminder.
Okay, time for another board-style question based on this section. Let's say you have a 68-year-old male who underwent an elective abdominal EVAR 1 month ago. His 1-month postoperative CT scan was entirely normal, no endoleak, stable sac size. He is now due for his 6-month follow-up visit. Based purely on the SVS guidelines, what is the most appropriate imaging study for this patient at this specific visit, and what's the rationale?
Okay, so the patient had a normal 1-month post-EVAR CT. He's now at the 6-month mark. According to SVS recommendation 6, which is strong, moderate evidence, if no endoleak or sac enlargement was detected during the first year, particularly on that crucial 1-month CT.
Which was the case here.
Right. Then Duplex ultrasound at 12-month intervals may be a reasonable alternative for surveillance. The guidelines explicitly state that the 6-month CT can be eliminated in favor of CDU as long as the endograft can be adequately imaged by ultrasound.
So the guideline directly addresses replacing the 6-month CT.
Yes, it does. Therefore, at this 6-month visit, assuming his endograft is imageable with ultrasound, Duplex ultrasound, including color duplex, would be the most appropriate imaging study according to the SVS guidelines push towards minimizing unnecessary CTs.
And the rationale?
The rationale is to minimize cumulative radiation exposure and the use of potentially nephrotoxic contrast agents, aligning with the evolving practice pattern where demonstrated initial stability allows for a less aggressive but still objective imaging strategy using ultrasound.
Excellent. Let's move on now and explore the mesenteric arteries. Chronic mesenteric arterial insufficiency, characterized by that classic postprandial abdominal pain, weight loss, it can be a really devastating condition if left untreated.
It absolutely can, potentially fatal. Treatment options, as you know, range from traditional open surgical reconstruction, things like transaortic endarterectomy or bypass grafts, to more commonly now endovascular approaches like balloon angioplasty and stenting, often using balloon expandable stents in the mesenteric vessels.
Mm-hmm. And how does durability compare between open and endo here?
Generally, open surgical repair is considered more durable long-term. However, endovascular intervention is performed much more frequently now, especially for patients who are frail or have significant comorbidities, because it offers lower peri-procedural morbidity and mortality.
So there's a trade-off. Less invasive, but maybe less durable.
Exactly. And
Mm.
that trade-off directly impacts surveillance needs, because endovascular mesenteric interventions have a higher risk of recurrent stenosis or occlusion compared to open surgery.
Great.
And because the consequence of a failed mesenteric intervention is so severe, potentially mesenteric infarction and death-vigilant surveillance becomes absolutely crucial. Clinical follow-up alone just isn't sensitive enough to pick up impending failures reliably. Both open and endovascular reconstructions require imaging surveillance.
So what methods are recommended for mesenteric follow-up, particularly using duplex ultrasound?
Duplex ultrasound is definitely the most common modality used.
Rare.
Ideally, patients should fast overnight to minimize interfering bowel gas.
Standard prep for abdominal ultrasound.
Right. During the exam, you'll obtain Doppler flow waveforms from the key vessels, the celiac axis, the splenic and common hepatic arteries, the superior mesenteric artery, SMA, and the inferior mesenteric artery, IMA, if feasible. You record peak systolic velocity, PSV, and end diastolic velocity, EDV, at multiple locations along these vessels, and any bypass grafts. Flow direction is also important. For example, reversed flow in the common hepatic artery can indicate a significant celiac axis issue.
Are the interpretation criteria well defined here, like in the carotids?
Unfortunately, no, that's a key challenge. There's a lack of really well-established, validated DOS criteria specifically for detecting recurrent stenosis after mesenteric interventions, either open or endo.
So using native artery criteria is problematic.
Yes, applying standard native artery criteria tends to overestimate the degree of restenosis after bypass grafting or stenting in the mesenteric circulation, similar to what we saw in the carotids post-stenting.
But are there at least some suggested thresholds we can use as a guide?
There are. The guidelines reference studies, like those by Abarama and Solt, that propose some thresholds based on retrospective data. For instance, looking at instant restenosis. For the celiac axis, a PSD threshold somewhere around 270 to 290 centimeters per second might suggest a significant, say greater than 70% ISR.
Okay. And for the SMA?
For the SMA, the numbers are higher. A PSV threshold, maybe around 410 to 445 centimeters per second, has been suggested to correlate with a greater than 70% ISR. Some advocate for just getting a baseline DUS post-intervention and then looking for significant increases in PSV from that baseline, or intervening if PSV exceeds something high like 500 centimeters. But these aren't universally adopted criteria. And there are really no published criteria for mesenteric bypass grafts specifically.
So it's an area with less definitive guidance on interpretation. How does that translate into the summary of recommendations?
Yeah. Given the uncertainty but the high stakes, the recommendations focus on consistent surveillance. Recommendation 1, strong, low evidence. This is driven by the potentially life-threatening nature of recurrent mesenteric ischemia. So for both angioplast stenting and bypass grafting, we recommend clinical follow-up plus a baseline duplex ultrasound within 1 month of the procedure.
Baseline within a month.
Then continued clinical follow-up and duplex ultrasound at 6 months, 12 months, and annually thereafter.
So quite a rigorous schedule despite the low evidence quality.
Yes, reflecting the severity of potential failure. Then recommendation 2, weak, low evidence. This addresses when to proceed to contrast imaging, like CTA or MRA. We suggest contrast imaging for patients who develop symptoms of recurrent mesenteric ischemia or if specific duplex ultrasound findings arise.
And what are those DUS triggers?
For the celiac axis, a PSV greater than 370 centimeters per second, or a substantial increase from the baseline PSV. For the superior mesenteric artery, a PSV greater than 420 centimeters per second, or again a substantial increase from baseline. The guidelines also mention a substantial increase in IMPSV, but acknowledge that substantial increase isn't precisely defined.
Okay, so using those higher velocity thresholds or a significant jump from baseline as triggers for further imaging.
Exactly. It's using DUS as a screening tool to identify patients needing more definitive imaging.
Got it. So to quickly recap this mesenteric section, the critical nature of potential recurrence makes vigilant duplex ultrasound follow-up essential, even though we face challenges with less validated DUS criteria compared to other vascular beds. The schedule is relatively intensive due to the high stakes involved.
Mhm.
And for our listeners, maybe recall those specific, albeit suggested, velocity thresholds for mesenteric artery, ISR, around 370 for celiac, 420 for SMA as triggers for concern, and perhaps ponder the implications of that weak recommendation for contrast imaging. How high does your clinical suspicion need to be in conjunction with these DUS findings?
Good points to consider.
Let's apply this. Here's a scenario. A 60-year-old patient, quite frail with significant comorbidities, underwent endovascular stenting for chronic mesenteric ischemia 3 weeks ago. Post-procedure recovery has been uneventful. According to the SVS Guidelines, when is the recommended baseline duplex ultrasound for this patient, and why is getting that early baseline so crucial here?
Okay. Based on SBS recommendation, one for mesenteric interventions, which is strong, despite low evidence, a baseline duplex ultrasound is recommended within 1 month of the procedure. So for this patient at 3 weeks post-stent, now would be the ideal time.
And the why. Why so important early on?
That early baseline is absolutely crucial in the mesenteric circulation. First, it establishes their specific post-treatment reference point, what their velocities look like immediately after successful revascularization. Second, it helps identify any immediate issues, like a significant residual stenosis that might have been underestimated on completion angiography. And third, it provides that vital benchmark against which all future surveillance scans will be compared. Given the potential for restenosis and the truly life-threatening consequences if mesenteric revascularization fails, establishing that accurate baseline early is paramount for effective long-term monitoring.
Makes perfect sense. Okay, before we move to the renal and lower extremities, let's take a moment for a bigger picture view, a sort of mega recap of everything we've covered so far. The carotids, the aorta, thoracic and abdominal, and the mesenteric arteries. What are the overarching themes?
Looking back across these major arterial beds, a few common threads really emerge, alongside some distinct challenges. A central theme is that achieving optimal long-term outcomes absolutely hinges on diligent, structured follow-up and being prepared for timely reintervention when necessary.
Surveillance is key.
Definitely. And we've seen the heavy reliance on non-invasive duplex ultrasound as the primary surveillance tool in most areas. It offers that objective anatomic and physiologic information generally safely and cost-effectively.
With caveats.
Right. We've repeatedly highlighted the ongoing challenge and critical importance of refining and correctly applying velocity criteria, especially after endovascular stenting, where flow dynamics are altered. We've also had to acknowledge the variable quality of evidence underpinning many of these guidelines. Lots of strong or weak recommendations based on moderate or low-quality evidence rather than high-quality randomized trial data.
True. The evidence grade was often B or C.
Exactly. But despite those evidence limitations, what remains crystal clear is the critical role surveillance plays in the early detection of potentially catastrophic complications. Think about endoleaks after aortic repairs, or hemodynamically significant restenosis in carotid and mesenteric arteries. Catching these early, often before symptoms develop, can make a profound difference in preventing severe morbidity and even mortality.
That's a great synthesis. Now let's turn our attention to the renal arteries. Reconstruction here is typically aimed at preserving renal function or managing severe refractory hypertension, usually linked to significant occlusive disease, right?
That's correct. The underlying cause is most often atherosclerosis, over 90% of cases, though fibromuscular dysplasia, FMD, is another important cause, particularly in younger women, and generally has better outcomes after intervention.
And the treatment approach has shifted here too.
Significantly. Open surgical repair, like bypass or endarterectomy, has largely been supplanted by percutaneous transliminal angioplasty, PTA, and stenting. However, it's absolutely crucial to acknowledge the findings from major randomized trials, like Astral and Coral.
What did they show?
They quite notably found no significant clinical benefit in terms of preserving renal function or improving blood pressure control long-term for renal artery intervention, primarily stenting, compared to optimal medical therapy alone, at least for patients with moderate atherosclerotic stenosis and hypertension.
So if the overall clinical benefit of intervention itself is debated for many patients, why is follow-up and surveillance still considered necessary after someone does undergo intervention?
That's the paradox, isn't it? Despite the debate on the ultimate clinical benefit for many patients initially selected for intervention, once an intervention is performed, restenosis is unfortunately quite common. Rates vary widely in the literature, but they can be substantial. Furthermore, recurrence rates after reinterventions for restenosis are also high. sometimes reported between 20 and 70%. And the fact that there isn't one clearly superior technique for treating renal artery in-stent restenosis further underscores the challenge. So surveillance becomes essential primarily to identify these common restenotic lesions, even if the decision of when or if to re-intervene on them remains complex.
I see. So it's about tracking the anatomical outcome of the intervention itself. What's the role of CT angiography versus duplex ultrasound for renal artery follow-up?
Well, CT angiography can be effective and sensitive for detecting restenosis, but is often not very specific for determining the hemodynamic significance. Plus, metallic artifacts from the stent itself can significantly obscure visualization right at the area of interest.
And the contrast issue.
Exactly. The need for iodinated contrast is a major drawback in this patient population, who often already have underlying renal insufficiency. So duplex ultrasound remains the most commonly used follow-up modality.
What does the DUS exam involve?
Similar to mesenteric, patients should ideally fast overnight. You use a lower frequency transducer, maybe 1 to 5 megahertz, to get adequate penetration. You record PSVs and EDVs in the supramesenteric aorta as a reference, and then throughout the renal artery segments, origin, proximal, mid, distal, and even into the healer branches if possible. Kidney length is also measured as an indicator of parenchymal volume.
And the key hemodynamic measurement.
A crucial measurement is the renal to aortic velocity ratio, or RRR. This is calculated by dividing the highest renal artery PSV found by the PSV measured in the supramesenteric aorta. This ratio helps normalize for systemic variations in blood flow, but it's only considered valid if the aortic PSV itself is within a reasonable range, say 40 to 100 centimeters per second.
And like elsewhere, criteria need adjusting post-stenting.
Yes, absolutely. Just like in the carotids and mesenterics, PSV is inherently increased after renal artery stenting due to the altered vessel compliance.
Right.
Therefore, using native artery criteria will overestimate stenosis, and modified criteria are essential.
What are the suggested modified criteria for renal ISR?
Again, these are based on limited studies and aren't universally validated, but the guidelines reference work suggesting thresholds. For example, Baker suggested back in 1999 that for detecting a greater than 50% diameter reduction, a renal artery PSV over 226 centimeters or an RAR over 2.7 might be indicative. More recent studies like Mohabats or Chai's suggest higher thresholds for higher grade stenosis, maybe a PSV around 280 centimeters and an RAR of 4.5 for over 60% stenosis, or even a PSV close to 400 centimeters and an RAR over 5 for over 70% stenosis.
So again, substantially higher velocities needed post-stent.
Correct.
Okay, let's summarize the SVS recommendations specifically for renal artery follow-up.
All right. Recommendation 1, weak, low evidence. This covers both angioplasty stenting and open bypass enterectomy. We suggest clinical follow-up plus a baseline duplex ultrasound within 1 month of the procedure.
Baseline again.
Then, continued clinical follow-up and duplex ultrasound at 6 months, 12 months, and annually thereafter. The guidelines note there are no prospective reports confirming the efficacy of this schedule.
So a suggestion based on limited evidence and common practice.
Pretty much. Then, recommendation 2, weak, moderate evidence. This suggests when to consider contrast-enhanced imaging, like CTAMRA. We suggested for evidence of loss of renal parenchyma, specifically defined as a decrease in kidney length of greater than 1 centimeter compared to previous scans.
Kidney shrinkage.
Or for specific duplex ultrasound findings. Those triggers are a renal artery PSV of 280 centimeters per second or greater, or a substantial increase from the baseline PSV, or a renal to aortic velocity ratio, or 4.5 or greater.
Using those velocity ratio thresholds we just discussed as triggers. Okay, so to quickly recap the renal artery section, we've really navigated some unique challenges here. There's the high prevalence of restenosis after intervention, the critical need for adjusted duplex ultrasound criteria post-stenting, and all of this is happening within the broader context of that ongoing debate about the overall clinical benefit of renal artery intervention itself for many patients with atherosclerotic disease.
A complex area, definitely.
And for our listeners, maybe take a moment to recall those specific threshold suggestions for renal artery in-stent restenosis, that PSV around 280 centimeters, or the RAR of 4.5. Now, consciously compare those numbers to the thresholds discussed earlier for the carotid or mesenteric arteries. How do they differ? What might that tell you about the unique hemodynamic environment or restenosis patterns in the renal circulation?
Interesting comparison to make.
All right, let's do our final board-style question for this section. You have a 70-year-old male with known atherosclerotic renal artery stenosis. He underwent renal artery stenting 3 months ago. His baseline duplex, performed within 1 month post-procedure, was documented as normal. Today, his follow-up DUS shows a maximum PSV of 310 centimeters per second within the stented segment of the renal artery, and a calculated renal to aortic velocity ratio, RAR, of 4.8. Clinically, his blood pressure remains difficult to control despite medication adjustments, and his creatinine has shown a slight increase compared to baseline. Based on the SVS guidelines, what is the most appropriate next step in his management?
Okay, let's break down those findings. The DUS shows a PSV of 310 centimeters and an RR of 4.8. These numbers strongly suggest significant in-stent restenosis. They meet the criteria mentioned in Recommendation 2 for considering further action. Specifically, they exceed the suggested PSV threshold of 280 centimeters and the RIR threshold of 4.5 for significant, likely 60% stenosis.
Right, the DUS is clearly abnormal by the suggested criteria.
Correct. And crucially, this isn't just an imaging finding. The patient is experiencing symptomatic deterioration, his hypertension is worsening, and his renal function is declining slightly.
So clinical correlation too.
Exactly. Therefore, based on SVS Recommendation 2, weak, moderate evidence, the combination of these objective DUS findings suggesting significant ISR and the clinical deterioration strongly suggests that contrast-enhanced imaging, like CTA or MRA or potentially catheter angiography, is indicated.
And the purpose of that?
To definitively confirm the presence and severity of the incidental restenosis and to help guide decisions regarding potential reintervention.
Makes sense. Excellent. Now, for our final major section, let's navigate the truly extensive landscape of lower extremity arterial revascularization. This covers a huge variety of procedures, doesn't it?
It really does.
Yeah.
Everything from major open surgical reconstructions like aortoiliac or infraguinal bypasses down to the vast array of endovascular procedures, angioplasty, stenting, atherectomy, performed from the aorta down to the tibial arteries. Generally speaking, though, the surveillance approach involves a combination of clinical assessment, checking the ankle brachial index, ADI, and of course duplex ultrasound.
And the rationale for follow-up here, what are we trying to catch?
The mechanisms of failure in the lower extremities are quite diverse. It could be inadequate inflow coming into the reconstruction or poor outflow going out, issues with the conduit itself like vein graft stenosis or prosthetic graft degeneration, intimal hyperplasia causing narrowing, especially the anastomotic sites, or simply the relentless progression of underlying atherosclerosis in adjacent native vessels.
So lots of potential failure points.
Indeed. And duplex ultrasound plays a particularly valuable role here because studies have shown that identifying and electively repairing graft-threatening lesions, particularly in vein grafts, before they thrombose, can significantly prolong patency and potentially prevent limb loss.
Okay, let's break this down. Starting with open lower extremity arterial revascularization. What are the key methods and surveillance considerations? Maybe beginning with aortoiliac procedures.
Right. For open procedures, physiologic testing, like the ABI, is useful for tracking overall limb perfusion, but it's generally less sensitive than DUS for detecting specific focal lesions that might threaten the reconstruction. DUS remains the primary imaging tool.
And what does the DUS cover?
A comprehensive exam covers the native inflow vessels, the native outflow vessels, the proximal and distal anastomoses, and the entire length of the graft conduit itself.
Okay. What about specific aortoiliac open procedures, like aorta bifemoral bypass?
Aorta bifemoral bypass, the gold standard for extensive aortoiliac disease, generally has excellent long-term patency rates, often reported as 88 to 93% at 3 to 5 years. Because patency is so good, there actually aren't many specific studies focusing on long-term surveillance protocols for this procedure. It's often just clinical follow-up unless problems arise.
What about other iliac reconstructions? Iliofemoral or femoral bypasses?
Iliofemoral bypasses are also quite durable. Femoral bypasses, however, generally have significantly lower long-term patency compared to aortobifemoral grafts, maybe only 35% primary patency at 5 years in some older series, compared to over 70% for aortobifemoral. However, some studies suggest that using DUS-derived criteria to guide preemptive revision of stenoses in fem-fem grafts can improve secondary patency rates.
Criteria like?
One study by Stone suggested using a PSV greater than 300 centimeters and a PSV ratio across the stenosis greater than 3.5 as triggers for revision, which reportedly improved patency.
And axillobifemoral bypasses, the extra anatomic ones.
Ax-fem bypasses inherently carry a higher risk of occlusion and other complications due to their length, subcutaneous course, course and often the poorer health status of the patients receiving them. There's limited literature specifically on surveillance protocols for them. Early studies reported decent patency, but didn't detail surveillance methods.
Okay, let's move down the leg to infraguinal revascularization, focusing first on open bypass using autogenous vein, the patient's own vein. What are the failure modes here, and how does DUS help?
Autogenous vein bypasses, often considered the best conduit for below-the-knee bypasses, have characteristic modes of failure over time. Early failures, within the first to 30 days, are usually due to technical error during surgery or poor patient selection. Midterm failures, say from 1 month to 2 years, are most commonly caused by intimal hyperplastic lesions developing within the vein graft itself, or at the anastomosis. Late failures, typically after 2 years, are more often due to the progression of atherosclerosis in the inflow or outflow arteries, or occasionally degeneration of the vein graft itself.
So that midterm intimal hyperplasia is a key target for surveillance.
Exactly. That's where DUS surveillance is potentially most appealing, detecting those stenosis before they cause graft thrombosis.
Are there specific DUS criteria to identify vein grafts at high risk of thrombosis?
Yes. Pioneering work by Van Dyke and others established criteria based on hemodynamic parameters measured within the graft. These help stratify risk.
Can you give some examples?
Sure. Parameters include the peak systolic velocity, PSV, at the point of maximal stenosis, the velocity ratio, VR, comparing the PSV at the stenosis to the PSV just proximal to it, and the overall graft flow velocity, GFE, measured in a non-stenotic segment, often reported as a time-averaged velocity. Changes in the patient's ABI are also factored in.
And how do these combine to stratify risk?
For example, the absolute highest risk category for impending thrombosis would be a graft with a focal PSV over 300 centimeters, a VR over 3.5, and a critically low GFE, less than 45 centimeters, often accompanied by a drop in ABI of more than 0.15.
Wow, multiple factors pointing to failure.
Right. Conversely, a low-risk graft would typically have PSVs under 180 centimeters, a VR less than 2.0, and a healthy GFE above 45 centimeters with a stable ABI. There are intermediate categories as well.
So DOS seems theoretically very useful here. What does the evidence actually show regarding the benefit of routine DOS surveillance for vein grafts?
This is where it gets contentious. The evidence is actually quite conflicting.
Oh.
Some early systematic reviews, like one by Gollage in 1996, found that while surveillance identified stenosis, it didn't clearly translate into better limb salvage rates compared to clinical follow-up alone. Some randomized controlled trials, RCTs by Elberg, also found no significant difference in primary, assisted primary, or secondary patency with DUS surveillance versus clinical follow-up, although these trials might have been underpowered.
So some negative or equivocal studies. Any positive ones?
Yes. A notable RCT by Lundell did show a significant benefit for intensive DUS surveillance, specifically for vein grafts, leading to much better assisted primary and secondary patency rates at 3 years compared to clinical follow-up alone, around 80% versus 55%. Interestingly, in that same study, prosthetic bypass patency was not affected by surveillance.
Okay, so maybe benefit for vein, but not prosthetic.
That study suggested so. However, another large RCT, the vein graft surveillance trial, VGST by Davies, found no difference in amputation-free survival or graft patency between intensive DUS surveillance and clinical follow-up only for vein grafts. But critics point out issues like non-standardized DUS criteria and many interventions happening in both groups in that trial.
So, still messy. What did the SVS systematic review conclude?
The SVS Guideline Committee performed its own systematic review and meta-analysis, looking at 15 studies. Their conclusion was that, overall, DUS surveillance was not associated with a statistically significant change in primary, assisted primary, or secondary patency, or mortality for infraguinal bypass grafts. There was a non-significant trend towards reduced amputation rates, odds ratio 0.70.
Not exactly a ringing endorsement.
No. They concluded that while the evidence quality is generally low, given that DUS is non-invasive and relatively low cost, it can be reasonably incorporated into individualized follow-up protocols, particularly for autogenous vein grafts. But the benefit isn't definitively proven by high-level evidence.
And for prosthetic infraguinal bypasses, like PTAFE grafts.
As the Lundell study hinted, and other retrospective reviews support, routine DUS surveillance for prosthetic bypasses below the inguinal ligament is generally not considered effective or useful for predicting failure. Some suggest very low graft flow velocities might predict failure and could support adding anticoagulation, but routine imaging surveillance isn't strongly recommended.
Okay, that's a complex picture for open infranguinal bypass. Let's switch gears now to endovascular lower extremity arterial revascularization, or EVT. As you said, its use has surpassed open surgery in many centers. What's the primary limitation we face after these procedures?
Without a doubt, the most important limitation is restenosis, generally defined as a greater than 50% diameter narrowing or sometimes greater than 75% reduction in cross-sectional area within the treated segment.
And what drives this restenosis after EVT? Is it the same as in vein grafts?
The pathophysiology is related but distinct. It's a complex biological response to the mechanical injury caused by the intervention. It involves an inflammatory response, platelet activation, cytokine and growth factor release, smooth muscle cell migration and proliferation, leading to intimal thickening and increased extracellular matrix deposition. A key difference often cited is that after stenting, neointimal hyperplasia within the stent is the main driver. After balloon angioplasty or atherectomy without stenting, restenosis is often thought to be a combination of this neointimal hyperplasia plus constrictive arterial, remodeling the vessel, sort of shrinking down over time. Atherosclerotic changes usually contribute much later, typically beyond 2 years.
What about stent fracture? We hear about that.
Stent fracture incidence varies widely in reports, from 2% up to 65% depending on stent type, location, and follow-up duration. However, the current literature generally suggests that stent fracture itself has little clinical impact unless it's associated with significant restenosis or the patient develops symptoms. So specific surveillance just for fracture isn't really established.
Okay, so restenosis is the main target. How well established are DUS techniques and criteria for monitoring after lower extremity EVT?
This is another area where things are still evolving and somewhat controversial.
Hmm.
Optimal DOS frequency and techniques are not as well established as for, say, carotid stenting or even vein graft surveillance. There are conflicting opinions on whether routine DUS offers significant benefit over clinical exam and ABI monitoring alone, especially for asymptomatic patients. Furthermore, the velocity criteria used to define restenosis in peripheral arteries after EVT are often extrapolated from other vascular beds or native vessel studies and may not be entirely valid or universally applicable, particularly after stenting alters compliance.
And the consequences of restenosis.
Reintervention for restenosis after EVT is common, costly, and unfortunately often has shorter patency than the original procedure. This highlights the desire to detect it, but also raises questions about the value of intervening, especially if the patient is asymptomatic.
Is a baseline DUS recommended after EVT?
Yes, strongly. A baseline DUS performed within the first month after lower extremity EVT is generally recommended for 2 main reasons. First, to establish that crucial baseline hemodynamic profile for future comparison. Second, and perhaps more importantly, to identify significant residual stenosis or other technical imperfections that might have been missed on the completion angiogram performed during the procedure. These residual lesions are associated with significantly lower long-term patency and increased risk of amputation, and secondary interventions on them often have poor results. Catching them early allows for potential correction before they lead to failure.
Okay, baseline DUS is key. Let's look at specific locations again, starting with aortoiliac EVT. How does surveillance work there?
Endovascular treatment for aortoiliac occlusive disease, usually with stenting, generally have excellent midterm and long-term results. Primary patency rates often reported in the 64 to 82% range at 5 years, with some studies even higher. Because the outcomes are generally good, there's actually limited specific DUS data guiding surveillance here. Some studies have proposed criteria, like a velocity ratio greater than 2.5, suggesting significant stenosis. But often, clinical outcomes weren't significantly different based on these findings alone. Another study suggested maximum PSV was most consistent, using a threshold over 300 centimeters.
So decisions are often clinical.
Frequently, yes. Decisions to re-intervene in the aortoiliac segment after EVT are often driven by the return of limiting claudication symptoms rather than solely by GUS findings. There's generally less concern for immediate limb threat compared to infranguinal interventions failing.
Okay. Now, what about the femoropopliteal segment, the SFA, and popliteal artery? This is probably the most common area for peripheral EVT, right?
Absolutely. It's the workhorse segment for PVI. But again, there are relatively few robust studies specifically evaluating the utility of routine DUS surveillance here.
Are there any suggested DUS criteria for FemPop ISR?
Some centers have published their criteria based on retrospective reviews. For example, one large review from Pittsburgh, looking at SFA stenting with DUS follow-up every 6 months after initial checks, proposed criteria for high-grade restenosis as a PSV greater than 300 centimeters and a velocity ratio greater than 3.5. They also suggested thresholds for 50% stenosis, PSV 190, VR 1.5, and 80% stenosis, PSV 275, VR 3.5. Another study about Shrikandi suggested PSV 223 and VR 2.5 for 70% stenosis. But correlation in the tibial vessels below was poor. It's worth noting that some trials involving complex stenting strategies, like the Vibrant trial, showed relatively low primary patency rates, but achieved high assisted primary and secondary patency rates. This was attributed partly to rigorous DUS surveillance protocols and judicious reintervention based on those findings.
But does intervening on asymptomatic restenosis found by DS actually provide clinical benefit?
That remains unclear and debated. Some argue, based on natural history studies like one by Bowie, that reintervention should primarily be based on the return of symptoms, not just DUS findings. Severe stenosis after EVT in the FEMPOP segment, unlike vein grafts, often remains asymptomatic and seems less prone to acute thrombosis. Therefore, intervening based on clinical findings might be more beneficial and avoid unnecessary procedures.
What about treating ISR when it occurs? Is it different if it's stenotic versus occlusive?
Treating femoral popliteal ISR is challenging. Procedural success rates for retreating occlusions versus non-occlusive restenosis might be similar initially, but subsequent failure rates, re-restenosis or re-occlusion, tend to be higher if the initial ISR presented as an occlusion. Reintervention for non-occlusive ISR is often driven by recurrent claudication, while occlusive ISR more commonly presents with critical limb ischemia.
Can DUS help distinguish symptomatic from asymptomatic ISR?
One study by Jones suggested a velocity ratio 2.5 was reasonably accurate for distinguishing symptomatic from asymptomatic patients after femoral popliteal EVT, though less so for iliac. However, they noted some asymptomatic patients with high VR did eventually progress to symptoms or require reintervention. It's not a perfect predictor.
Okay, there are clearly suggested velocity thresholds out there. Can you summarize some of them from the tables in the guidelines?
Yes, Table 10 in the guidelines compiles criteria from various studies, Tinder, Burrell, Bowie, Shrikandi, for grading lower extremity angioplasty site and instant restenosis. Generally, for a 50% stenosis, PSV thresholds range from 190 to 250 centimeters, and velocity ratios from 1.5 to 2.5. For more severe stenosis, 70% or 80%, PSV thresholds are typically higher, ranging from 223 to over 300 centimeters, and velocity ratios from 2.5 to 3.5 or even higher. But again, these vary between studies and aren't universally validated.
Got it. Finally, let's touch on tibial artery revascularization using EVT. What are the key considerations here?
Tibial artery EVT is performed almost exclusively for patients with critical limb ischemia, CLI, rest pain, or tissue loss. Patency rates historically are quite low, and restenosis rates are very high in these small vessels. Some DUS criteria have been suggested, like a PSV 300 centimeters and VR 3.5 indicating severe restenosis. However, the clinical reality is that if a patient with a prior tibial intervention presents with worsening wounds or recurrent rest pain, they will likely proceed to angiography regardless of DUS findings.
So, clinical status often overrides DUS.
On the setting of CLI and tibial intervention, often yes. Restenosis in a tibial vessel carries a high risk of limb loss. One study showed 27% limb loss with restenosis versus 4% without. Patients frequently require further interventions. While frequent clinical follow-up is absolutely essential for limb salvage, the added utility of routine DUS in this setting is questionable if that close clinical assessment, including wound checks and ABI, is already happening. Clinical assessment and ADI might actually be better guides for decision-making here.
A very challenging area. Okay, let's try to bring this all together with the SVS recommendations for lower extremity arterial revascularization surveillance.
Well, let's summarize these final recommendations. Recommendation 1, strong, low evidence, is for aortoiliac EVT. We recommend clinical examination, ABI measurement, and duplex ultrasound within the first month, primarily for that baseline assessment and to check for residual stenosis.
Okay, baseline combo for aortoiliac EVT.
Then follow up with clinical examination and ABI measurement with or without duplex ultrasound at 6 and 12 months, and then annually thereafter if the patient remains free of new symptoms.
So DUS becomes optional after baseline if asymptomatic for aortoiliac.
Correct. Recommendation 2, weak, low evidence, addresses femoral popliteal EVT. Again, we suggest clinical examination, ABI, and duplex ultrasound within the first month for baseline and residual stenosis check. However, continued surveillance, specifically including DUS, is suggested at 3 months and then every 6 months thereafter for 2 specific subgroups. First, patients who receive stents.
Why specifically stents?
The rationale given is the potential increased difficulty of successfully treating an occlusive instant restenosis compared to a stenotic one, making earlier detection potentially more valuable.
Okay. And the second subgroup?
The second group is patients who underwent angioplasty or atherectomy without stenting, specifically for critical limb ischemia. The rationale here is their increased risk of recurrent CLI if the intervention fails.
So more intense DUS surveillance suggested for FEMPOP stents or CLI interventions.
Yes, that's the suggestion. Finally, recommendation 3, weak, low evidence, covers tibial EVT. We suggest clinical examination, ABI, and duplex ultrasound within the first month for baseline assessment. Continued surveillance is then suggested at 3 months and every 6 months thereafter.
Similar schedule.
Similar suggested schedule, but with an important addition. Repeat duplex ultrasound should be performed promptly if there is any deteriorating clinical vascular examination, return of rest pain, non-healing wounds, or development of new tissue loss, regardless of the scheduled interval.
So DUS triggered by clinical change in tibial CLI patients.
Exactly, emphasizing the primacy of clinical assessment in this group.
Okay. So, to quickly micro-recap this very extensive lower extremity section, the recommendations really try to distinguish between open and endovascular approaches and between different arterial segments, aortoiliac, FEMPOP, tibial. They emphasize risk stratification considering factors like conduit type, vein versus prosthetic, presence of stents, and initial indication, claudication versus CLI. And throughout, there's that recurring theme of ongoing debate regarding the true clinical utility and cost-effectiveness of routine duplex ultrasound surveillance, particularly for asymptomatic patients after endovascular interventions.
A very accurate summary of a complex area.
And a final thought for our listeners on this section. Consider those different duplex ultrasound velocity thresholds we touched upon, the ones used for infrainguinal vein grafts versus those suggested for lower extremity EVT, particularly post-stenting. How do they differ? What might those differences reflect about the underlying pathology's intimal hyperplasia in a compliant vein versus neointimal hyperplasia within a rigid stent, perhaps? Or maybe just the lack of robust validation in the EVT space?
Worth pondering.
All right, let's tackle our final board-style question for the entire deep dive. You have a 55-year-old male with critical limb ischemia who underwent femoropopliteal artery stenting 1 month ago. His 1-month baseline duplex ultrasound revealed no significant residual stenosis, and the stent appeared widely patent. He is currently asymptomatic from a vascular standpoint, and his initial wound is showing good signs of healing. Based on the SVS guidelines, what is the recommended follow-up schedule for this specific patient moving forward, and what is the primary rationale given for this frequency?
Okay, so this patient had femoropopliteal artery stenting performed for critical limb ischemia. Based on SVS recommendation 2, weak, low evidence for femoropopliteal EVT, continued surveillance is suggested at 3 months and then every 6 months thereafter.
So the more intensive schedule applies here.
Yes, because he falls into both subgroups mentioned in that recommendation. He received a stent, and the indication was critical limb ischemia.
In the rationale.
The primary rationale cited in the guidelines for this increased surveillance frequency in stented FEMPOP arteries, especially when placed for CLI, relates to 2 main concerns. First, the potential increased difficulty and perhaps poorer outcomes associated with treating an occlusive versus a merely stenotic in-stent lesion, making early detection of stenosis desirable. And second, that heightened risk that failure of the intervention in a CLI patient will lead directly back to recurrent critical limb ischemia. Therefore, this more vigilant surveillance aims to detect developing problems early, ideally before symptomatic recurrence or occlusion occurs.
Excellent summary. Okay, for our final mega recap, let's try to synthesize the key surveillance points, specifically for the renal and lower extremity revascularizations we just covered.
Looking at both the renal and the extensive lower extremity sections together, the overwhelming common theme remains the challenge of restenosis. It's a major limiting factor for the long-term success of both open and, perhaps especially, endovascular procedures in these territories.
Restenosis dominates.
It really does. And duplex ultrasound continues to play that central role as our primary non-invasive tool for monitoring these reconstructions. However, as we've discussed extensively, there's still significant ongoing debate and evolution regarding its precise utility, the optimal surveillance frequency, and particularly the most accurate and validated interpretation criteria, especially following endovascular interventions where altered hemodynamics and lack of large-scale validation studies remain issues.
Right, the criteria are often suggested, not definitively proven.
Exactly. And this really underscores the crucial importance, especially in the renal and lower extremity fields, of integrating patient-based clinical outcomes. symptom status, functional capacity, wound healing, limb salvage, alongside the imaging data when making critical management decisions. The imaging informs, but the clinical picture often guides.
A perfect concluding thought for the core content. This deep dive has truly been illuminating. It's highlighted both the structured guidance that is available from the SVS Guidelines, but also, very clearly, the significant gaps in high-quality Grade A evidence that still exist across many of these arterial procedures and follow-up strategies.
That's very true. We've seen that while achieving optimal outcomes clearly depends on periodic follow-up and appropriate timely reintervention, and while non-invasive vascular lab tests like Duplex ultrasound are invaluable tools providing objective information, much of the specific guidance regarding how and when to perform that surveillance stems from moderate or low-quality evidence or expert consensus rather than definitive RCTs. It was striking that none of the 24 formal recommendations made by the expert panel were actually graded as having high-quality evidence supporting them.
Really underscores the point. And it means these recommendations are likely to continue evolving as new data emerges, doesn't it?
Absolutely. This field is constantly changing, which leads to a final thought, perhaps a provocative one for you, our specialist listener.
Go ahead.
Given the rapid innovation we see in vascular interventions, new devices, new techniques, and our constantly evolving understanding of atherosclerosis and stenosis, what specific areas of post-procedure follow-up and surveillance do you personally believe are most ripe for dedicated, high-quality clinical research right now? Where do we most need better evidence?
And perhaps just as importantly, how will you, as a practicing specialist clinician, navigate these inevitably evolving guidelines in your own daily practice? How will you balance adhering to the current recommendations with maintaining an adaptable, critical approach as new evidence emerges, always striving for the best possible long-term outcomes for your individual patients?
So important questions to consider.
Indeed. Thank you so much for joining us on this very detailed deep dive. We sincerely hope this comprehensive review of the SVS follow-up guidelines empowers your practice and benefits your patients.